Imagine trying to embroider a really highly complex, detailed pattern onto a sheet of wet tissue paper.
Oh, wow. Yeah, that's a stressful visual.
Right. I mean, you have this incredibly sharp, rigid steel tool in your hand, but your canvas, the material you're working with, has absolutely no structural integrity.
None at all.
One wrong move or like one tiny application of excess pressure and the whole thing just disintegrates in tears. And that precarious high-stakes scenario is exactly what a doctor faces when injecting fluids into aging, highly fragile human tissue.
It is the absolute definition of a microscopic tightrope walk. I mean, the margin for error doesn't just shrink in those environments. It practically vanishes completely.
Yeah, it just disappears.
You're operating in this biological landscape that is just incredibly unforgiving, where standard mechanical precision suddenly has to compete with sheer fluid dynamics and cellular degradation.
Which brings us to the mission for today's deep dive. We are exploring a highly specific, fundamentally fascinating medical reality. Okay, let's unpack this. We are unpacking the exact risks of localized hematoma formation when performing sub-mucosal micro-droplet injections in vascularly fragile atrophic tissue.
I know it sounds incredibly dense when you say it like that.
It's a mouthful, yeah.
It is. But when we break down the actual physics and the biology happening right at the tip of that needle, it is nothing short of extraordinary.
And to really figure this out, we're pulling together clinical insights from a wildly diverse stack of medical literature. We're looking at data from dentistry, aesthetic dermatology, gynecology, and gastroenterology.
A really broad spectrum.
Exactly. Because whether you are a patient considering a cosmetic procedure or maybe undergoing a medical restorative treatment for mucosal tissue loss, or even if you just love understanding the extreme hidden engineering of the human body, this conversation reviews what actually happens when sharp metal meets our most delicate biology.
And to really grasp the magnitude of the risk here, we have to start by examining the canvas itself. Before we talk about the fluid or the needle, we have to understand the specific tissue we're trying to inject.
Right.
The medical term here is vascularly fragile atrophic tissue.
So let's break that down for everyone listening, starting with the environment itself, right? The submucosal layer. Because this isn't the tough outer skin we're used to dealing with.
No, not at all.
The submucosa is that spongy, highly vascularized layer of connective tissue sitting right beneath the mucous membrane, so like the inside of your cheek, the wall of your stomach, or delicate reproductive tissues.
Yeah, it's very distinct from the dermis.
Right. And then we add the word atrophic to it, which
Yeah.
essentially means a physical wasting away or a really profound thinning of that specific biological layer.
Exactly. And that thinning, it's essentially a structural collapse. To visualize this, let's look at two very clear clinical examples from the sources where this happens. The first is vulvovaginal atrophy, which is a condition frequently seen during menopause. Now, in a healthy state, estrogen acts as this primary signaling molecule that basically tells the body to constantly produce plump, resilient collagen and elastin fibers in those tissues.
But then menopause hits.
Right. As estrogen and androgen levels naturally decline, that signaling just stops.
The factory shuts down.
The cellular factory completely shuts down. The tissues undergo this profound structural degradation. You see a massive decrease in elasticity, a significant reduction in the adipose tissue, which is the protective fat padding.
Oh, I see.
Yeah, and an overall thinning of the mucosal lining itself, which paradoxically leads to an increase in overall tissue sensitivity and pain.
So the tissue literally loses its physical shock absorbers.
Exactly.
And we see a similar mechanical failure in the second example, which is senile purpura. And this is driven by decades of chronic sun exposure combined with the natural aging process.
Yeah, the UV damage.
Yeah, UV radiation physically degrades the elastin fibers in our skin over time, almost like imagine a rubber band that's been left out in the sun on a car dashboard for years.
Oh yeah, it gets brittle and just snaps.
Exactly, it snaps. Over decades, this causes severe damage to the connective tissue scaffolding within the dermis.
Which leads us to why that loss of scaffolding matters so much when a sharp needle is introduced. I mean, we need to talk about the blood vessels themselves.
Right, the pipes.
Right. In youthful, structurally sound tissue, your blood vessels are heavily supported. They're cushioned by this robust, dense matrix of collagen, elastin, and fat. So when a needle pushes past them, that padding absorbs the shock and allows the vessel to just gently slide out of the way.
But in these atrophic states, that padding is entirely gone. The blood vessels are essentially left naked inside the tissue.
Naked and completely tethered to degrading support structures. They're stripped of their protective matrix. So that makes the vessel walls incredibly prone to leaking, tearing, or just fully rupturing under even the slightest mechanical stress.
Which brings us back to the wet tissue paper analogy. In healthy tissue, injecting fluid is like embroidering on thick canvas or denim. The structural fibers hold everything together, but in atrophic tissue, those structural fibers have dissolved.
The canvas is wet tissue paper.
Yeah, the biological material itself has lost the ability to resist mechanical force.
Which perfectly sets the stage for the primary injury we're talking about today, the localized hematoma. And we really need to differentiate this immediately from what people typically think of as just a bruise.
Right, they aren't the same thing.
Not at all. A simple bruise, or ecchymosis, is a minor, self-limiting leakage of blood from a few tiny capillaries. A hematoma is a localized, abnormal, active collection of blood outside of a blood vessel.
It's actively pooling.
Yes. It forcefully pools and collects in one anatomical space, eventually forming this very distinct, palpable blue or purple bulge under the skin or the mucosa.
Now, our bodies are famously efficient at fixing leaks, usually. Our blood vessels are under constant active repair. The moment a micro tear happens, the body triggers this highly complex clotting cascade. Platelets rough to the site, they stick together, and signal for fibrin strands to weave this microscopic net.
Essentially slapping a biological patch over the hole in milliseconds.
Right, but a hematoma forms when that brilliant repair mechanism is completely overwhelmed.
Exactly. If a needle causes extensive ragged damage to a naked vessel, or, if the practitioner accidentally nicks an artery that's under tremendous hydrostatic pressure, the sheer force of the blood pumping out of the tear physically blasts the fibrin patches away before they can set.
Wow, it just blows the patch right off.
It does. The blood just keeps leaking through the damaged wall faster than the body can patch it. The mechanical pressure of the circulatory system simply overpowers the body's natural sealant.
So we have a naked vessel and an overwhelmed clotting system. But what is causing that initial ragged damage during these sub-mucosal micro-droplet injections? I mean, beyond just a bad angle.
Well, the obvious culprit is just an aggressive insertion angle, sure, or a practitioner blindly advancing the needle into a dense vascular bed. But there's this deeply fascinating and honestly quite visceral mechanical hazard we see highlighted constantly in the dental block procedure sources.
Oh, the barbed needle.
Yes, the barbed needle.
This specific mechanism is terrifying to picture.
It really is.
I mean, a brand new medical needle has a microscopic, incredibly sharp, beveled edge designed to slice cleanly through tissue.
Clean being the operative word there.
Yeah.
But when a practitioner is navigating the sub-mucosal layer, if the tip of that needle accidentally taps against underlying bone, or even if the exact same needle is just inserted and withdrawn multiple times to deliver multiple scattered microdroplets, that delicate microscopic bevel at the very tip can bend backward on itself.
It turns into a microscopic harpoon.
A literal fishhook made of steel.
Yeah.
And because the barb is facing backward, the needle might still glide into the tissue relatively smoothly.
But pulling it out is the problem.
Yes, the damage happens on the way out. When the practitioner withdraws the syringe, that microscopic barb snags the tunica adventitia, that's the fragile outer layer of those naked blood vessels, and violently shreds it from the inside out.
Ugh, that sounds awful.
It drags the tissue, tears the vessel walls, and causes this massive, entirely unnecessary vascular trauma.
Wait, but if we're specifically talking about injecting into the submucosal layer, isn't that anatomical zone basically a minefield of blood vessels anyway?
Oh, absolutely.
Because if we look at the gastroenterology data, particularly the studies on endoscopic submucosal dissections in the upper stomach, they explicitly note that the submucosal layer is packed with extremely large diameter vessels. If a patient's tissue is that dense with vasculature, how does a practitioner realistically ever avoid hitting a vessel, barge needle, or not?
Well, the truth is, they often don't. You really can't guarantee you won't hit a blood vessel, especially in a blind injection beneath an opaque mucosal surface. And that is the crucial pivot point in this entire field of medicine. Since intercepting a vessel is always a statistical probability, how you deliver the liquid payload becomes the ultimate deciding factor between a flawless procedure and an expanding catastrophic hematoma.
Here's where it gets really interesting. This is where we shift from the sharpness of the needle to the physics of the plunger. The deposition rate, meaning the physical speed at which a practitioner pushes the fluid out of the syringe, is a massive, independent variable in tissue trauma.
It is. The clinical term for getting this wrong is tissue ballooning. You have to visualize the interstitial space within the submucosa as this very confined, incredibly fragile compartment.
Right.
So when a practitioner depresses the plunger too rapidly, the liquid rushes into that delicate vestibule and forces it to distend abruptly. It's a massive volumetric shock to the area.
It's basically the difference between gently filling a small water balloon from a trickling tap versus shoving a high-pressure fire hose into that same balloon and just cranking the valve open.
That is the exact perfect analogy.
The sheer kinetic force of the fluid rapidly expanding violently rips the surrounding tissue fibers apart. And because those blood vessels are already naked and unsupported in atrophic tissue, the tidal waves of injected fluid simply tears them open from the outside.
Yeah, that sudden mechanical shearing force is devastating. But injecting fluid too quickly carries an even darker, much higher stakes risk, one that is heavily documented in the aesthetic dermatology field when dealing with facial dermal fillers.
Retrograde embolization.
Exactly. Retrograde embolization.
This is truly the nightmare scenario for any injector. Walk us through the actual physics of how this happens.
Well, it essentially comes down to a battle of pressure differentials.
Yeah.
Let's say the sharp tip of the needle happens to rest perfectly inside the hollow center of a small facial artery.
Okay.
If the practitioner pushes the plunger with high manual pressure, the force of the fluid exiting the needle can actually overcome the patient's systolic arterial pressure, meaning the force of the injection is temporarily stronger than the peak pumping force of the patient's own heart.
The filler is literally shoved backward.
Push backward against the natural flow of arterial blood, deep into the vascular network. And in the face, this retrograde flow can travel up the supratrochlear artery, past the orbital rim, and directly into the ophthalmic artery system, which supplies blood to the eye.
Oh my God.
And the very second the practitioner stops pushing the plunger and the pressure equalizes, the heart's next beat slams that column of thick filler forward, instantly blocking the retinal vessels.
Resulting in instantaneous irreversible blindness or massive facial tissue necrosis, all because the plunger was pushed a fraction of a second too fast.
Precisely why the clinical guidelines across all these disciplines, from dental anesthetics to facial aesthetics, establish an ironclad golden rule. You must slow down.
Slow down.
The dental literature explicitly dictates that it should take one full uninterrupted minute to safely administer a standard 1.8 milliliter cartridge of local anesthetic.
1 minute holding a needle perfectly still inside sensitive tissue? I mean, that feels like an eternity for both the patient and the doctor.
It does feel like an eternity.
Yeah.
But that excruciatingly slow deposition rate is what gives the confined tissue time to physically accommodate the incoming fluid volume. The tissues can slowly stretch and expand rather than violently tearing.
But let's look at the reality here. Even if a practitioner has the patience of a saint, a perfectly calibrated deposition rate, and manages to avoid the barbed fishhook effect, a sharp needle moving through wet tissue paper skin is still an inherent massive hazard. So how has the medical community engineered a way around the sharp edge itself?
This brings us to one of the greatest mechanical debates in modern injectables, which is the industry-wide shift from sharp, hypodermic needles to blunt-tipped microcannulas.
And a cannula, for those trying to picture it, is essentially a tiny, flexible, hollow tube. It doesn't have a sharp point at the end.
Right. The blunt tip fundamentally changes how the tool interacts with human anatomy. Needles carry a highly documented vascular risk simply because they ruthlessly pierce every single structure in their direct linear pair.
They just cut through everything.
Exactly. They also cause something called plane migration, where the injected fluid tracks backward along the physical cut the needle just made, depositing product into the wrong anatomical layer. Plus, to cover a wide area, a needle requires multiple entry points through the skin, vastly increasing the trauma and bruising footprint.
And the blunt cannula mitigates all of this because of how it moves through the tissue. When a flexible blunt cannula is advanced through the submucosal layer, it doesn't slice. It acts more like a microscopic snowplow.
A snowplow, exactly.
It essentially dissects the tissue bluntly, gliding over and under the tiny vascular networks, gently nudging those naked blood vessels out of the way rather than cutting through them.
And what's fascinating here is the clinical safety data backing up this mechanical shift. It is staggering. When we look at large-scale complication registries in dermatology, the numbers paint a very clear picture. When practitioners utilize sharp needles for facial filler, they see a severe vascular occlusion risk of roughly 1 in every 6,410 injections.
Which is already quite rare, but still a significant statistical risk when you think about how many injections happen a day.
Right. But when those same practitioners switch to utilizing blunt cannulas, that risk plummets to 1 occlusion per 40,882 injections. That is a massive, statistically undeniable reduction in catastrophic vascular events. The blunt snowplow effect works.
Okay, wait, I have to challenge the absolute safety of that mechanism. If the data proves cannulas are this magical snowplow that just gently nudges vessels to safety, how are we still seeing any vascular occlusions at all? 1 in 40,000 is incredible, but it isn't zero. The blunt tip clearly isn't entirely foolproof.
And that is the exact nuance that separates a good practitioner from a master of anatomy.
Okay.
The cannula snowplow effect relies entirely on the blood vessel having empty physical space to move into. The vessel has to be mobile. But human anatomy is highly complex. If a larger artery is anchored or relatively fixed in place by surrounding fascial bands or bone, and the practitioner approaches that fixed artery perpendicularly with a blunt cannula, the vessel can't slide out of the way.
It's trapped against a biological wall.
It is trapped, and this is where the bluntness actually becomes a severe liability. Because a cannula isn't sharp, advancing it through tissue requires slightly more manual forward force from the doctor.
Right, you have to push harder.
Exactly. When that blunt, forceful tip finally breaches a trapped, stretched artery, it doesn't just make a clean, tiny puncture like a needle would. The blunt force trauma tears a massive, ragged, devastating hole in the vessel wall, resulting in a severe, rapidly expanding bleed that is incredibly difficult to stop.
So the tool designed to prevent the tear can actually cause a worse one under the wrong anatomical conditions.
Furthermore, the surface area of the cannula tip dictates its safety. A very fine-tipped cannula, something like a 27 gauge, has such a microscopic surface area at the tip that all the forward force is concentrated on a tiny point. Physics dictates that it acts almost exactly like a sharp needle. It will easily pierce right through a mobile vessel rather than pushing it aside.
So whether a doctor chooses a sharp needle or a blunt cannula, the ghost of a massive hematoma is always lingering in the room, especially in atrophic tissue. Which brings us to the final and arguably most important phase of our deep dive today, damage control. How do practitioners manage this high wire act, both in the days before the needle touches the skin and in the chaotic seconds when a vessel inevitably tears mid-injection?
Well, the risk mitigation starts long before the patient is ever sitting in the clinical chair. In patients known to have vascularly fragile tissue, pre-procedure protocols are absolute non-negotiable. The patient must cease taking all blood-thinning agents a full 7 days prior to the injection.
And we aren't just talking about major prescription anticoagulants like warfarin.
No, not at all. The medical literature places massive emphasis on over-the-counter supplements. NSAIDs, high-dose fish oil, vitamin E, St. John's wort, garlic capsules, and ginseng.
I mean, I think a lot of people brush off things like garlic and ginseng as just harmless holistic supplements. How are they actually causing hematomas?
It comes down to cellular biochemistry. Garlic contains a compound called allicin, and ginseng contains ginsenosides. Both of these actively interfere with thromboxane A2.
Thromboxane A2.
Yeah, it's a lipid that platelets desperately need in order to clump together and initiate the clotting cascade we talked about earlier.
Oh, wow. So they chemically sabotage the body's ability to weave that fibrin patch.
Exactly. In young, highly elastic tissue, slightly sluggish platelets might just result in a minor bruise. But in unsupported, atrophic sub-mucosal tissue, chemically delaying that fibrin patch by even a few seconds guarantees that the hydrostatic pressure of the blood will form a massive pooling hematoma.
Okay, so the patient is prepped, their platelets are fully functional, and they're in the chair. The procedure begins. What specific mechanical actions is the practitioner taking to prevent a catastrophic bleed?
2 highly deliberate movements. First, they must manually pull the mucosa tight before inserting the tool. Creating high surface tension stabilizes the loose atrophic tissue planes beneath, greatly reducing the chance of the needle snagging, dragging, or rolling the vessels.
Making the canvas as taut as possible.
Yes. And second, and this is the vital safety check, they must aspirate.
Aspiration. That is the physical act of pulling backward on the syringe plunger before pushing any fluid in, right?
Correct. That negative pressure is your early warning system. Once the needle or cannula is resting at the desired depth in the tissue, the practitioner pulls back gently on the plunger and hold it for a few seconds. If the tip of their tool is resting inside the lumen of a blood vessel, that negative pressure will draw a tiny flash of red blood up into the hub of the syringe.
Giving them a visual confirmation that you are in the danger zone.
Exactly. If they see blood, they immediately abort the injection in that specific tract, completely preventing a devastating intravascular delivery or embolization.
But let's play out the worst-case scenario. They aspirate, it's clear. They start injecting at a perfectly slow deposition rate. But the tissue paper still tears. A naked vessel ruptures, and suddenly the tissue begins rapidly ballooning, and a dark purple bulge starts forming under the skin. What is the immediate emergency protocol?
Absolute, immediate cessation of the injection. The very second an expanding hematoma is visually evident, the needle comes out. The practitioner must instantly apply firm, sustained manual compression directly to the area.
Just squeezing it, essentially.
You have to literally use your fingers to externally oppose the hydrostatic pressure of the leaking artery, trapping the blood and giving those platelets a calm environment to finally lay down the fibrin patch. Simultaneously, you apply severe cold ice packs to induce rapid vasoconstriction, physically shrinking the diameter of the torn blood vessels to staunch the flow.
And beyond the physical compression, there's one final incredible safety net mentioned in the clinical sources, and it relates specifically to the actual chemical material being injected.
Right. The choice of the microdroplet itself is arguably the biggest safety decision a practitioner makes.
Because when we look at the data for submucosal augmentation, whether it's facial aesthetic contouring or mucosal restorative procedures, the vast majority of modern practitioners have shifted almost entirely to utilizing hyaluronic acid, or HA fillers. And the reason for this is a massive structural safety differentiator.
HA fillers provide a crucial biological failsafe. Hyaluronic acid is a naturally occurring sugar complex in the body. If a severe vascular compromise occurs with an HA filler, whether a massive hematoma forms that threatens tissue viability or the ultimate nightmare of an arterial occlusion happens, the practitioner has an emergency chemical undo button.
They can literally dissolve the mistake.
They immediately flood the area with an injectable enzyme called hyaluronidase. This enzyme specifically targets and cleaves the molecular bonds of the hyaluronic acid filler, breaking it down into harmless water and sugar almost instantly. It rapidly removes the physical pressure on the blood vessels, clears the occlusion, and restores vital blood flow to the dying tissue.
Which is wildly, fundamentally different from the older generation of permanent fillers.
Oh, it is night and day. If a practitioner causes a severe vascular complication, utilizing a permanent synthetic filler like PMMA, which is essentially composed of microscopic polymethyl methacrylate acrylic spheres suspended in collagen, you cannot chemically dissolve it. There is no enzyme for acrylic plastic.
So what do?
The only way to remove the blockage and save the surrounding tissue from necrosis is through emergency surgical debridement.
You literally have to take a scalpel, cut open the patient's face or mucosal tissue, and physically scrape the synthetic material out of the wound.
Which, when you are already dealing with crumbling, vascularly fragile atrophic tissue, that level of secondary surgical trauma is utterly devastating to the patient's anatomy.
It really highlights the central theme of everything we've explored today. If we connect this to the bigger picture, the human body's vascular network is, under normal circumstances, a highly resilient, forgiving system. But when you transition into the realm of atrophic tissue where the structural scaffolding has rotted away and the vessels are laid bare, your margin of error simply vanishes.
It really does.
The strict pre-procedure supplement bans, the painstakingly slow fluid deposition, the mechanical shift to blunt cannulas, the rigid aspiration protocols, and the reliance on reversible HA enzymes. These aren't just polite suggestions or clinical best practices. They are entirely non-negotiable biological safety barriers, keeping a routine aesthetic or medical procedure from instantly turning into a surgical emergency.
It truly is a masterclass in risk mitigation. You're attempting to rebuild and inflate a biological structure on a foundation that is actively crumbling, and every single physical and chemical variable has to be ruthlessly controlled.
So what does this all mean? Well, that perfectly wraps up our mission for today. Injecting microdroplets into submucosal atrophic tissue is never just a simple medical task. It is a high-stakes, microscopic balancing act. It requires a profound understanding of fluid dynamics, three-dimensional anatomical knowledge, and incredibly precise tool selection.
Absolutely.
But I want to leave you with a final thought to ponder, if you're listening, something that builds on the incredible biology we've unpacked today. We learned that our blood vessels are under constant active repair by our body's own clotting cascades. Platelets and fibrin constantly fighting to patch microtears against the relentless hydrostatic pressure of our own blood.
Right.
So, what if the future of injectable medicine isn't just about passively avoiding these vessels with blunt snowplow cannulas or relying on reactive post-injury dissolving enzymes? What if the next massive leap forward is engineering smart fillers, injectable liquids that are chemically designed to instantly trigger a localized microscopic coagulation cascade the exact millisecond they detect the unique chemical signature of a ruptured blood vessel? Imagine a dermal filler that acts as its own autonomous emergency fibrin patch, sealing the leak before a hematoma can ever form.
A self-sealing biological matrix. Now,
Yeah.
that would fundamentally rewrite the rules of minimally invasive medicine entirely.
Something fascinating to think about the next time you or someone you know is sitting in a clinical chair looking at a needle. Thank you for joining us for this deep dive. Stay insanely curious, and we will catch you next time.